Good afternoon. So presbyopia probably is the last frontier in ophthalmology where we are still don't have a perfect solution. Of course, we have got various options, but to a perfection mark, it still is lacking. So we have got various options. We may do corneal procedures like laser. We can do Cambra inlays, or we can have phakic IOLs, and we can do refractive lens exchange. So I'll be covering multifocal IOLs and EDOF for this purpose. So we have to understand that presbyopia is a progressive problem. It's not a stationary thing. A 40-year-old presbyopic may be different from a 60-year-old presbyopic. So once you are choosing a procedure, you have to be very clear what is the age of patient, and as Dr. Rohit has pointed out, you have to look about the lens clarity also. You have to see there is any changes in the lens. If it's turning yellow, that means you need to change the lens. That will be better. In early 40s, probably LASIK is a better choice. So coming to the multifocal and extended depth of IOLs. So all we know, the conventional IOL is a single focus, and near vision is a problem in these cases. The people have tried to do multifocal lenses in various ways. It started long back in 1982. But the credit goes to John Pierce in 1986, who was to implant the bullseye lens of the multifocal IOL. So by definition, single IOL with two or more foci is a multifocal IOL. Most of the IOL we have got now multifocal so-called are bifocal IOLs, but they are again multifocal, right? So the types we have got is the refractive, diffractive, or maybe combination of the both. So the refractive IOLs, it has got two zone lens. There's a concentric rings all around, and annulus type of the lens, bullseye, it's dependent on the pupil. So it has to be very, very well centered. Diffractive multifocal IOLs, these IOLs utilize the principle of diffraction in conjunction with refraction to create two foci. The basic refractive power is provided by the anterior aspheric surface, and the diffractive power comes from the multiple grooves on the posterior surface. It's not a pupil dependent, so even a slight decentration may not cause much problem in diffractive IOL. But refractive IOL has to be very, very well centered. Your axis has to be perfect, everything has to be perfect, otherwise it will cause you a lot of problems. The main limitation of multifocals are the presence of glare, halos, and reduced contrast sensitivity, which is seen to be improved with bilateral implantation. You did one, patient will have complaint. So if you are going to do multifocal lens, try to do within a month of the two lenses. That will give you better accommodation, better adjustment, and a bilateral summation effect will take most of the problems. This is the Tecnis IOL. We can see there's a modified Prolite anterior surface optic that neutralizes the positive aspherical aberration of the human cornea. There's a refractive multifocals. They are good for excellent intermediate and distance vision, while the diffractive multifocals are excellent for reading and very good distance vision. The most recently introduced accuracy of Restore is the apodized diffractive IOL. The unique feature of Restore lens is that it has apodized diffractive optics. The term apodization derived from the Greek literally means cutting the feet off. So there are the sharp points, only the feet are cut off, so that makes apodization of the lens. The concept of apodization means gradual transition of optical properties from the center of lens to the edge. This is the Restore. I'll not go in detail of technical details. So we have got multifocal toric also, which is from 0.5 to 3, now even much more than that. Then what are the preoperative consideration? If we decided to go for multifocal, the patient should have a strong desire to be spectacle independent. If the patient is not desired, don't push it. This is the single most important indication for multifocal lens surgery. Age, by and large, it would be better to operate within 35 to 75 years. After 75, there are some pathologies in the macula and fovea. The patient may not be very happy with the result. Functional occupation required, a detailed history on the point is most crucial. Does the patient have any hobbies like painting, playing, piano? Basically, you have to look for what is his lifestyle is. What are the things he's going to use? He's going to use more of intermediate vision. He's going to use more of near vision. Or he's a driver who has to drive in the night also. So these things has to be considered. And patient is multitasking or is doing only paperwork. These things matters a lot. And of course, you have to rule out the ocular pathologies like ARMD, glaucoma. And we know that there is a decrease in the contrast sensitivity in these patients So avoid in diabetic patient also. If the patient are very hypercritical and demanding, the patient want very perfect vision, they are in a profession like photography or where the very sharp vision, like the bank person who has to work on the lasers, who has to work on the books also, who has to work on the computer, it's better to avoid these patients. And again, the patient who are very cynical and suspecting patients who remains unhappy no matter how best we perform. Such are the patients who will remain more bothered with the halos and mild transient glare which may be present initially. So there should be strong urge for near reading without glasses. These avid users will be very happy with apodized diffractive multifocal lenses which has very good unaided near vision. So patients who are doing more of reading or close work, a diffractive lens will be better choice. The night drivers, for all these patients, even short-term glare or halo effect will be intolerable. So you have to counsel these patients with explaining them about the potential side effects. Also the fact that they are easily tolerable with binocular summation and lesson from the time is very crucial. So what are the intraoperative exclusion criteria? If there is a significant vitreous loss, don't try to do it. Pupil trauma during surgery, if there is a journal damage, if there is a rexus tear, if there is a capsule rupture, avoid in these cases putting a multifocal. A monofocal may be more forgiving in these cases. So what are the keys for successful multifocal IOL implantation? The patient selection should be the most important thing. Second is the accurate biometry. If your results you are getting good with your optical, I want you to use optical biometry and your results are very good with monofocal, then try using multifocal. And all the readings has to be checked twice. If you don't have an optical biometer, then immersion biometry can be used. So power calculation, maximize visual outcome by calculating a post-op refraction spherical equivalent from planar to 0.25. Use of newer formulas like Hill RBF or Barrett's formula, they are much better. And naturally we have to have a very good CCC. It should cover the lens optics and removal of all viscoelastic from behind the lens and proper position of the lens in the capsular bag. What are the disadvantages with multifocal? They causes light intensity entering the eye is halved. In bull eye lenses, amount of light transmitted to each of focal lens varies with pupil size. Thus, distant and near objects may be of different intensity. In diffractive lens, image intensity is equal for distance and near vision, but even in LD situation, only half the light enters on one focus. Contrast sensitivity is decreased in these cases, so you have to be very careful. Even more light may be lost due to scattering. Thus, patient with multifocal may require brighter light to read well and generally function less well in dim light. Off-axis aberration in decentered IOL because more problems in multifocals compared to conventional IOLs. Okay, so where we have to do it, keenly interested in spectacle independence, easygoing personality with positive attitude, would accept small compromise on distance vision, willing to understand that this is not a procedure with guaranteed results. That's very important. And better if little hypermetropic patients. No, where should not use it, does not mind wearing glasses, don't do in those cases. Hypercritical patients with unrealistic expectation want very sharp vision, especially for near, heavily dependent on intermediate vision or night driving, commercial pilots, truck or taxi drivers, and low myopes also not a very good candidate for multifocals. Then comes the extended depth of focus. That means simply we increase the depth of focus or the range of vision is increased. EDOFILs offer better intermediate performance and less light scatter there compared to monofocal IOLs and smaller halos than multifocal IOLs. Technics Symphony IOL is the first one to come inside. This IOL has a biconvex wavefront design interior aspheric surface and a posterior achromatic diffractive surface with an eclate design. Achromatic is again very, very important because it takes a lot of aberrations. This is the Technics lens. This is again Zeiss from Zeiss. It's a condition cataract or presbyopic or astigmatism we can use, wishing to attain spectacle independence for most deliveries. Driving frequently is night, sensitive to halos and glare. So these are the different lenses, but the choice you have to make depending on the patient. So there's not say one shoe fit to all. You have to choose the procedure. Of course, refractive lens exchange is one of the procedure, and you have to judiciously considering the patient's requirement and his lifestyle. Thank you.